This lecture will focus on substance use disorder in adolescents and also substance use disorder during pregnancy, which impacts child and adolescent outcomes. In the context of the DSM-5 and different diagnoses, when you discuss substance-related and addictive disorders, it is essentially split into either substance intoxication, substance withdrawal, or substance use disorder. It can be difficult to diagnose substance use disorder in adolescents, and that's due in part by prevalent casual usage of substances during those years. It's also due in part to specific drugs being more socially acceptable in use in certain areas, and so even if individuals are using those drugs frequently, it's not necessarily viewed as problematic. There's also comorbid diagnoses in which the symptoms of those conditions will mask substance use disorder. And we know that adolescents are very frequently, they will hide their substance use. When we talk about adolescents hiding their substance use, it comes from them having a fear that what they share with a provider might be disclosed to their parents or guardians or even legal authorities, and they're fearful that this might have negative consequences for them. So that brings up the topic of confidentiality, and really we know that confidentiality can increase the degree of comfort and safety that a pediatric patient feels in sharing critical information to our assessment process in order for us to make an accurate diagnosis and formulate an effective treatment plan for them. We need all of the information, or as much information as we can gather. So even if you live in a state in which a minor must receive consent from their parent or guardian for every medical care encounter, then what you can do is you can utilize a split visit model. So many times you will allow for the parent to come back with their child, adolescent, and you will begin the appointment and discuss from the child's perspective, the adolescent's perspective, and the parent's perspective the most recent information, or if it's a new intake, you'll gather both sides as to why they are coming in. And then you will ask if it's all right for the parents to step out into the hall, and if you can speak with the patient alone, allowing for a confidential conversation. And these confidential conversations are key to providers being able to screen for substance use disorders, risky behaviors, to screen early and intervene early so as to minimize any potential negative outcomes and really optimize positive health outcomes in these adolescent patients, because we know the adolescent years are a time of development and there is ongoing brain maturation. And you can see in the image here that the blue represents maturing of brain areas, and there's not even a full coating of blue until you reach roughly 20 years of age. So sustained substance use during these adolescent years can negatively impact neuropsychological functioning, and that has negative outcomes: attention deficits, memory problems, decreased cognitive flexibility. These are all things we know, which is why when you consider the pathophysiology of substance use, it is so important to be able to identify that in this range of patients. In 2021, 32% of high school students reported using alcohol, tobacco, or marijuana, or even reported that they misused prescription opioids. From 2019 to 2020, deaths due to drug overdose among adolescents nearly doubled from 2019 to 2020, from 282 deaths to 546 deaths. Here you can see deaths due to drug overdose among adolescents, and from 2015 to 2020 you see that steadily increasing. From 2019 to 2020 you see that nearly double. But something I wanted to point out was that in 2019, 150 adolescent males overdosed, and that number more than doubled for males in 2020, going up to 331. Here you can see a spread specific to 2021 of high school students reporting substance use related to alcohol, tobacco use, marijuana, and prescription opioids. Substance use disorders are characterized by problematic patterns of use leading to significant impairment or distress across a 12-month period of time. These are some screening tools you can utilize in adolescent patients. And it's important to recognize risk factors in the adolescent patients that you come across. So that could be a family history of substance use, favorable parental attitudes towards substance use, poor parental monitoring, family rejection, association with delinquent or substance-using peers, lack of school connectedness, low academic achievement, childhood sexual abuse or trauma history, and comorbid mental health disorders. When you try to design treatment for adolescent patients with substance use disorders, it's important to remember that there are currently no FDA-approved addiction medications for use in adolescents. However, many providers will use them off-label for older adolescents or when indicated based on severity of the substance use disorder and the patient's history. You can also utilize behavioral approaches such as 12-step facilitation, CBT, group therapy, motivational enhancement therapies, family-based therapies such as brief strategic family therapy, family behavior therapy, multisystemic therapies, functional family therapy. It would also be very beneficial to treat presenting symptoms with medication management when indicated. And recovery support services are key. That would include things like peer recovery support or mutual help groups. So let's get started with the discussion surrounding substance use disorder treatment considerations during pregnancy. We're going to focus specifically on those for alcohol use disorder during pregnancy and opioid use during pregnancy. Pregnant and parenting people with substance use disorders experience a great deal of stigma, and it's important for us as providers to utilize tools that can minimize their reception of stigmatization, at least during their encounter with us. And so some tools that you can utilize are person-first language and unconditional positive regard. It's important to continue to believe that these individuals are competent and capable and that they are inherently good and they are there seeking care, and you can utilize things like motivational interviewing to hopefully create some better conversations surrounding behavior change. And it's always important to deliver trauma-informed care when approaching these patients. Certainly, abstinence from all substances during pregnancy and breastfeeding would be the safest option, but as providers, we have to realistically promote harm reduction strategies because not all patients are able to achieve abstinence and some simply don't want to. So, if you can't eliminate that risk and harm entirely, you should really aim to minimize it. So, strategies that patients can implement include tracking the amount of use, setting limits on their use, when, where, how much, making sure that they're attending support groups and remaining engaged in psychotherapy. As a provider, you should assess their support network and help to build that up, right? And making a parenting plan, if patients do choose to use still, is so important because you have to ensure the safety of that infant or child who will be watching that infant or child, tending to that infant or child's needs if the parents do engage in those behaviors still. This graphic from the CDC clues us into the prevalence of alcohol use disorder during pregnancy, or alcohol use in general during pregnancy. This is just between 2018 and 2020. In the past 30 days, 1 in 7 pregnant women reported drinking alcohol, and 1 in 20 pregnant women reported binge drinking. We are aware of a multitude of associated risks with alcohol use during pregnancy. That could include miscarriage, stillbirth, development of physical, behavioral, and intellectual disabilities in children. The most common non-heritable cause of intellectual disability is fetal alcohol spectrum disorders, and the full range of those disorders is prevalent in about 1 to 5 per 100 school children within the US and some Western European countries. It is simply a result of intrauterine exposure to alcohol use by the mother. Fetal alcohol syndrome itself is specified when there are severe physical and developmental disabilities. However, the spectrum of disorders could range in degree of impairment or associated pathologies. So there could be impact on the auditory system, potentially difficulties with speech and language delays. As an infant, you could have difficulties with sleep and sucking. There could be associated vision issues, cardiac abnormalities, GI issues, musculoskeletal, orofacial, like cleft lip, cleft palate. There could be psychiatric neurobehavioral disorders like attention difficulties, hyperactive behavior, poor memory, difficulty in school, associated learning disabilities, poor reasoning and judgment skills. It could lead to substance use disorders in the future for those children, mood disorders, oppositional defiant disorder. And it's also important to note that there are renal implications for the children as well, potentially, from intrauterine exposure to alcohol. There's also concern for polysubstance use in pregnant women who utilize alcohol. So in a national survey, it was found that about 10% of pregnant women did report drinking alcohol in the past 30 days, having at least one alcoholic drink. And of those women, 40% also reported using other substances, for instance, tobacco and marijuana. And polysubstance concerns are not just specific to alcohol use disorders, but they are prevalent across the realm of substance use disorders. So a study published in 2020 found that among women who continued marijuana use before and during pregnancy, 74% also smoked cigarettes during their pregnancy. A 2017 study found that more than half of pregnant women who used opioids for non-medical reasons reported drinking more than 5 drinks with alcohol per day during a 1-month stretch of time. And a 2015 study found that pregnant women prescribed opioid pain medication were more likely to smoke tobacco as compared to those who did not use prescription opioids. So treatment considerations could be broken up into what you as a PMHNP can do for pregnant mothers and also what you could do for children. So let me actually talk about the children first. For any children for whom you suspect fetal alcohol syndrome disorders, you should certainly evaluate for neurobehavioral complications, because intervention prior to 12 years of age is associated with better outcomes. With pregnant mothers themselves, obviously prevention would have been the best situation, right? By contraception use in women with known alcohol use disorders. But once already pregnant, it's very important for providers to screen for alcohol use. So an example of that is the TASER-3. You could, and a score of 3 or higher for that is a positive screen, but you could also utilize some of your other more conventional screening tools for alcohol use. And we did review those actually in your NUR715, so I won't put too much talk into that right now. And then, as we already discussed, harm reduction strategies are huge for patients for whom abstinence is not a possibility. And there is very limited research on the potential harm to the fetus and the forming infant from alcohol use disorder medications used in treatment. However, some more limited evidence shows that antabuse may be the only one that has potential harms to the fetus. So you could potentially consider naltrexone or acamprosate for use in your pregnant mothers with alcohol use disorders. Those two have very little indication of risk to the forming child. There are also off-label considerations that you could potentially utilize for these patients, and that would be, again, on a case-to-case basis, weighing the risks, most importantly during the first and third trimesters. Some off-label considerations could be Zofran potentially. Zoloft or Prozac are risk level category C in pregnancy. Gabapentin is actually risk level category C as well. So just some things to think about. In 2019, 7% of women reported using prescription opioid pain relievers during pregnancy. 1 in 5 of those women reported misuse of prescription opioids from a non-healthcare source or for a reason other than relieving pain. The number of women with opioid-related diagnoses at time of delivery has increased by 131% between 2010 and 2017. In 2020, data from the AHRQ showed roughly 1 infant diagnosed with NAS, or NOWS, also known as NOWS, every 24 minutes. So that's over 59 newborns diagnosed daily in the United States. The number of babies born with NAS or NOWS has increased by 82% nationally between 2010 and 2017, and those increases were seen in nearly all states and demographic groups. In the context of opioid use disorder, mothers are at increased risk for severe maternal morbidity, including eclampsia, heart attack, or heart failure, and sepsis. That can also be applied to amphetamine and cocaine use disorders as well. We know that children born to mothers who have been suffering from opioid use disorder during pregnancy are small for gestational age at birth with low birth weights. Oftentimes they are preterm with reduced head circumferences, and there's increased risk for sudden infant death syndrome as well as neonatal abstinence syndrome. And NAS is now referred to as NOWS. The same harm reduction strategies that we spoke about for alcohol use disorder treatment during pregnancy should be applied to opioid use disorder treatment during pregnancy as well. Relative to medication management for opioid use disorder during pregnancy, it's important to avoid abrupt discontinuation of opioids, inclusive of buprenorphine or methadone during pregnancy because of withdrawal risk and even the potential for unhealthy use following a period of abstinence. When offering buprenorphine treatment or referral for methadone treatment, providers should discuss the maternal fetal risks and benefits of both of those medications, and treatment should, if possible, be based on the patient's preference. You should educate patients who take opioids during pregnancy about the risks of NAS in their infants, also known as NOWS, neonatal opioid withdrawal syndrome, and inform these patients that breastfeeding while taking buprenorphine or methadone is safe and could reduce the risk of NOWS or even the severity of symptoms. Providers should not recommend naltrexone initiation because it requires withdrawal from opioids in a pregnant patient who is actively using opioids. Before initiating buprenorphine in a pregnant patient with OUD, providers should confirm that the patient is experiencing at least mild withdrawal symptoms and consult with an experienced substance use provider regarding the precipitated withdrawal. You should advise patients who take buprenorphine or methadone during pregnancy, and also those who become pregnant while taking it, to continue treatment throughout the duration of their pregnancy, labor, delivery, postpartum, and breastfeeding timeframes. At each visit, providers should monitor pregnant patients taking buprenorphine for opioid cravings and withdrawal symptoms, and if those are present, increase the dose as appropriate and reassess the following visit. Any dose increase should be maintained until the treatment goals can be evaluated postpartum. If a pregnant patient is considering a change from methadone to buprenorphine, the clinician should consult an experienced substance treatment provider because of, again, precipitated withdrawal. Feel free to pause at this point and review these considerations in choosing methadone or buprenorphine for opioid use disorder treatment during pregnancy, particularly running through the settings, the initiation requirements, safety, efficacy, treatment duration, the effects on the infant particularly, and then pain management and breastfeeding indications as well. And here also you can see the benefits and risks of continuing or discontinuing naltrexone usage during pregnancy. Thank you all for going through this lecture.